Hello guys and welcome back to Counter 10. My name is Ani and today we're going to be covering two topics on our episode. The first topic is looking at electrophysiology and the second topic is looking at sleep and EEG. This is both part of our series covering neurophysiology and pain. Now this is one topic where if you wanted to skip doing a deep dive into the learning objectives and just look at the model pass SAQ answers, that might suffice as enough knowledge for the exam, especially if you're time poor and are trying to cram in a lot of things. However, we will go through the learning objectives as per normal in this episode, and the electrophysiology topic itself used to have many more learning objectives attached to it, but now they've been spread across cardiac physiology, cellular, metabolic, and endocrine physiology, so it makes it really easy with just one learning objective to cover for this episode. So with that said, let's dive straight into it.
1, 2, 3, 4.
The first learning objective today is describe the physiology of nerve conduction. Now this is actually quite a broad topic and it takes in some points that we've already discussed in our previous episodes, specifically looking at our previous episodes from our cardiac physiology series. So I'm just going to do a quick refresher, mainly going through what resting membrane potential is first, and then I'll look specifically into nerve conduction physiology. Now remember, resting membrane potential, or RMP, is the defined steady state potential difference that exists across the cell membrane. There's two main factors that drive an RMP. The first is the selective permeability of ions, and the second is the different concentration of ions both inside and outside the cell. Out of these two factors, the most important is the membrane permeability rather than the concentration of ions. Now when we talk about membrane permeability, the key ion that should come into your head is potassium. Potassium can easily pass across the cell membrane while sodium cannot. And how we know this is using the Nernst equation. The Nernst equation calculates the potential difference that any ion would produce if the membrane was permeable to it. In simple words, what this is telling us is what the electrical gradient has to be to offset the concentration gradient. Remember, there are two forces that are trying to act against each other, the electrical gradient and the concentration gradient. And that Nernst equation helps to tell us what that electrical gradient must be to offset that concentration gradient. And so we're going to approximate a Nernst potential for each ion. For potassium, this is minus 90 millivolts. For chloride, this is minus 70 millivolts, and for sodium, this is positive 60 millivolts. Now, normal RMPs for neurons are roughly between minus 60 to minus 70 millivolts. What this tells us is that while potassium is the main factor, it's not the only factor that helps create this RMP. We can also use a second equation, known as the Goldman-Hodgkin-Katz equation, that can help us better understand the key factor of membrane permeability. Within this equation, it accounts for all the ions and all the membrane permeabilities for each one of these individual ions. In doing so, it tells us that ions that contribute most to the RMP will first have the largest membrane permeability, second, have the highest concentration present, and third, have the largest transmembrane gradient. So these two equations, being the Nernst equation and the Goldman-Hodgkin-Katz equation, help us to better understand how potassium and its membrane permeability is a chief contributor to our RMP. But this isn't the only factor to our RMP, like we've stated. The other minor factors that determine RMP that you should mention if you ever get a question about this is the effect of the NAK ATPase pump, the Gibbs-Donan effect, which hopefully you remember is the presence of large non-diffusible negatively charged moieties inside the cell affecting the distribution of permeable ions. And then finally, the last factor is the effect of chloride, because chloride's Nernst equation is also quite low and it plays a huge role whether an action potential continues to propagate or it ceases. Talking about chloride is a nice way to segue into talking about nerves themselves and doing a deeper dive of looking at nerve conduction physiology. Now first, we have to look at the structure and the makeup of a nerve itself. A nerve is made up of some really key structures, starting with the dendrites, which can take in information from other nerves that are connected to the main cell body of the neuron, aka the soma. From the soma you have the axon hillock, which is then connected to the axon itself, and at the end of the axon you have the axon terminal, where further impulses can be released into the synaptic cleft, which can then join onto neighboring neurons. An action potential in a neuron can simply be defined as rapid changes in the membrane potential that spread rapidly along the nerve fiber membrane. There are some successive stages in an action potential that happen in a majority of neurons, and this starts off with the neuron being in a resting state, then having a depolarization state, followed by a repolarization state, which has both an absolute and a relative refractory period, followed by a hyperpolarization state, and then finally a return to the resting state. As you can imagine in a neuron, these events are mainly catalyzed by first, fast voltage-gated sodium channels opening, followed by their closure, and then the restoration of that RMP through sodium-potassium ATPases. Within neurons, there are key characteristics that are part of any action potential. The first of which is that it's an all or none response. Once threshold is reached, there will be an action potential fired. The second is that the size of the action potential is not affected by the stimulus intensity. The third is that nerve transmission of information is proportional to the frequency of the action potentials. And then the fourth and final is that the action potential is associated with a refractory period. Within these characteristics, to firstly get to that all or nothing response, there needs to be a stimulus, and that stimulus comes from neighboring neurons that is then received by the dendrites of that neuron. Now these inputs can be one of two types of inputs. They can either be excitatory or inhibitory. If they're excitatory, then they're called excitatory postsynaptic potentials. If they're inhibitory, they're called inhibitory postsynaptic potentials. As you can imagine, with excitatory postsynaptic potentials, these would typically lead to an opening of voltage-gated sodium channels, while inhibitory often lead to the opening of potassium or chloride channels. This stimulus that the postsynaptic neuron is getting can either be from just one presynaptic neuron itself, known as temporal summation, or it can be from multiple presynaptic neurons, known as spatial summation. And to complicate things even further, you can have a combination of both excitatory and inhibitory postsynaptic potentials occurring. But if that threshold is reached, then you get that all or nothing response. Once that all or nothing response starts, the speed of that action potential down the axon is determined by one of two things: whether that nerve is myelinated or unmyelinated. And this is a really important concept to understand when it comes to nerve conduction physiology. Generally, an axon which is large in diameter will propagate an action potential faster than a smaller diameter axon because of that larger cross-sectional area. However, the main factor determining speed is whether it's myelinated or unmyelinated. In unmyelinated nerves, that action potential moves slowly because it's like a slow-moving wave going down that axon itself. It has to wait for that neighboring voltage-gated sodium channel to open, and then that leads to the next sodium channel opening, and so on and so forth. However, with myelinated nerves, you get a property that's called saltatory conduction. Now what this refers to is having insulation around the nerve, causing the action potential to jump from one area of no insulation to the next area of no insulation, known as spaces called nodes of Ranvier. Now that myelination is either produced by glial cells for axons that are within the central nervous system, or by Schwann cells for axons within the peripheral nervous system. So when you hear the term saltatory conduction, this is simply just referring to that action potential jumping between those nodes of Ranvier. This leads us nicely into the last thing with this first learning objective, which is then how do we classify nerves? Broadly speaking, there are two main classification systems. There's the Ellinger-Gasser system, and then there's the Lloyd-Hurst system. The former classifies nerves based on thickness and velocity, while the latter classifies nerves based on diameter and conductance. Regardless, If you can remember the broad nerve fiber types, their approximate diameter, and their approximate velocity, you will be fine for majority of MCQs and potential SAQs. So in saying that, I remember the Ellinger-Gasser system, which divides the nerve types into A fibers, B fibers, and C fibers. A fibers are further subdivided into A alpha, A beta, A gamma, and A delta, going from biggest diameter to smallest diameter, and subsequently the highest velocity to lowest velocity. B fibers are your last myelinated fibers, and C fibers are your only unmyelinated fibers. And because of this, I remember their diameter and their velocity, which is roughly the same. So their diameter is roughly 0.5 to 1, while the velocity is 0.5 to 2 meters per second. While on the top end, your A alpha fibers have a velocity that's between 60 to 120 meters per second. You will generally find your A fibers in skeletal muscle, in joints, in the transmission of touch and pressure, while you'll find your beta fibers important in your preganglionic autonomic nervous system, and then your C fibers important in your pain pathway. Now, there's not been too many SAQs that have asked specifically that information, but it is important to know for potential MCQs. Now that's pretty much as deep of a dive I can do into this one learning objective without boring you too much. So that completes our electrophysiology topic, and it moves us on to our next learning objective, which looks at sleep and EEG. And the first learning objective for this is outline the difference between normal sleep and anesthesia, including EEG. Now there's many ways you can define sleep, but I find the easiest way to define sleep is by first having a good definition of what consciousness is. If you think about consciousness as a state of being aware and responsive to one's surrounding, and on the contrary, sleep as being a state that's associated with unconsciousness from which one can be aroused from. The exact role of sleep is unknown, but it's thought to be restorative and regenerative. And for sleep to occur, there are two nuclei that are central for sleep. The first is the locus coeruleus, which secretes serotonin and is essential for slow wave sleep, and then the raphe nucleus, which secretes noradrenaline, which then stimulates REM sleep. Additionally, melatonin, which is released from the pineal gland, is important for initiating that process to go off to sleep. Now, everyone's sleep architecture is slightly different. Typically, we quote that in adults, you need a total between 7 to 8 hours of sleep. In neonates, that can be as much as 18 hours, and in elderly, this can be less than 7 hours. Within a normal sleep cycle, each sleep cycle is roughly 1.5 hours or 90 minutes, and 15 to 20% of that is REM sleep. This can be more if you're tired. It's more in neonates, which roughly makes up 50% of their sleep cycle, and it's less in elderly. To help better outline the physiological effects of sleep and the difference between sleep and anesthesia, you can create a table in your brain which has the effects of sleep on each individual system, and then in terms of the columns, you have REM sleep and non-REM sleep. When we look at the central nervous system first and see what are the effects non-REM sleep are having here first, we can see that as you start going off to sleep, you go through 4 stages of non-REM sleep. Stage 1 is a person drifting into sleep, and here you'll see some alpha waves starting to occur. Alpha waves are between 8 to 12 Hz, and these may be interdispersed with some theta waves between 4 to 8 Hz. Then you go into the second stage of sleeping, which has occasional bursts of high frequency that you can see as sleep spindles, typically high between 13 to 14 Hz, and occasional large biphasic potentials known as K complexes. These you don't see during anesthesia and are unique to sleep itself. Then you go into stage 3 of sleep, which is that high voltage delta wave sleep. And delta waves are those low frequency, high amplitude, less than 4 Hz waves that characteristically give you that seesaw pattern. Finally, you have stage 4 of sleep, which again you will see those large amplitude, rhythmic, slow delta waves, and between stage 3 and stage 4, this is what we classify as your restorative sleep. In opposition, during REM sleep, you'll see the characteristic patterns of high frequency, low amplitude waves that resemble the person looking awake, and these are more closer to beta waves, which typically sit between 14 to 30 Hz. REM sleep itself has two phases as well, which are less well known, but are described as either tonic phase, where you get a marked inhibition of muscle tone, and phasic phase, where you get a marked increase in motor activity, and that's when you see the rapid eye movements and when you experience dreaming itself. Now, both these types of sleep have contrasting effects on your brain blood flow as well as your brain oxygen demand. As expected, non-REM sleep decreases your CMRO2 by approximately 25 to 40%, decreases your sympathetic output, increases your parasympathetic output, decreases your cerebral blood flow. In contrast, REM sleep leads to an increase in CMRO2 by up to 20%, an increase in cerebral blood flow by up to 50%, an increase in sympathetic output, and a decrease in parasympathetic output. On the cardiovascular system, these effects are mirrored. With non-REM sleep, you get a slowing of your heart rate, a decrease in your systemic vascular resistance, and a decrease in your blood pressure. While with REM sleep, you get an increase in your heart rate, especially in the phasic phase, and you get an increase in your systemic vascular resistance. Again, you see these differences within the respiratory system. Within non-REM sleep, you get a progressive decrease in minute ventilation, secondary to a decrease in rest rate and tidal volume by up to 15%. You get a decrease in your upper airway muscle tone, which leads to increased airway resistance and therefore is a risk for OSA. You get a decreased response to both hypoxic and CO2 drive, and your baseline CO2 rises to around about 45 millimeters of mercury. All these effects are actually somewhat exacerbated in REM sleep. With REM sleep in particular, you get a further decrease in your airway tone despite there being increased motor activity, and this profound decrease in airway tone can lead to a further increased risk of OSA. You get a variation or irregular breathing pattern, which can either lead to a normalization of the minute ventilation or a decrease in the minute ventilation. You get further decrease in the suppression to hypoxia and a further increase in your CO2 levels. So if you were to say which one of these phases is more at risk for the respiratory system, it's going to be during REM sleep as compared to non-REM sleep. Then we can look at the differences within the musculoskeletal system within these two types of sleep. As expected, they both lead to a decrease in muscle tone, but that decrease in muscle tone is again exaggerated within REM sleep. Finally, when you look at the endocrine system, there are also some key differences. Within non-REM sleep, particularly the late stages of non-REM sleep, you might start to see a decrease in both insulin and glucose levels, as well as a release of ADH. While in REM sleep, you get an increase in growth hormone levels, and classically, as you get closer to waking up in the early hours of the morning, you get a rise in your cortisol levels. While you're sleeping, your overall metabolic rate is decreased by 15%, and this is reflected in your core body temperature also being decreased by 0.5 degrees. Your normal responses to your temperature decreasing are also lowered, so that's classically why you don't shiver while you're sleeping. So that's a broad overview of sleep, and you can see how those specific changes are very different to the changes that happen during anesthesia. This leads us on to our second learning objective and our final learning objective for today, which is outline the basis of the EEG. We've already started to kind of mention some key terms within the EEG, being the types of waves going from the highest frequency, being gamma oscillations, which we haven't mentioned prior, but are waves with frequencies between 30 to 80 Hz, and are observed when the patient is aroused and awake, and particularly in high focus, followed by beta waves, which sit between 14 to 30 Hz, then alpha waves, which sit between 8 to 13 Hz, followed by theta waves, which sit between 4 to 8 Hz, and then delta waves, which sit less than 4 Hz. As the frequency decreases, the amplitude of these waves increases, and that's when you start to get that nice seesaw pattern. What an EEG is a measure of the spontaneous electrical activity that's occurring in the brain. It's generated by looking at the specific neurons which are within the superficial layers of your pyramidal cells in the cerebral cortex, both generating those inhibitory and excitatory postsynaptic potentials. These tiny electrical potentials are modified by bone and soft tissue of the head before they are recorded by scalp electrodes, then processed by low and high frequency filters and displayed on an 8 or a 16 channel EEG waveform. The three basic types of activity that are caught on EEG include firstly, the continuous and rhythmical waves, secondly, the transient waves, and thirdly, the background activity. When you're looking at an EEG, usually they should be symmetrical between both the hemispheres, and when you're looking at an EEG of a conscious patient, what you should see is a slow, high frequency, low voltage, irregular waveform, compared to someone who's sleeping, which should look more regular, synchronized, high voltage, and low frequency. The clinical utility of using EEG, or more so processed EEG, in the anesthetic setting is mainly 1, to help us guide the depth of anesthesia, and 2, it can be an indirect marker for cerebral ischemia. If you're not getting any waveforms or a decrease in waveforms, you might be getting ischemia in the cortical areas of the brain. And you can see that sometimes when your EEG or your BIS recording drops and the patient's blood pressure is low, and when you raise that patient's blood pressure, suddenly you've got a much higher BIS reading than previously. In saying that, what kind of EEG output do you want to be seeing when you're giving someone a general anesthetic? Typically, you want to be seeing that slow delta wave seesaw pattern correlating with a number between 40 to 60. If you're getting isoelectric waves followed by a jolter wave activity, that suggests that you're too deep in your anesthetic and that you have burst suppression. And this is a key EEG finding which is characteristic to being under a general anesthetic versus being asleep. So this is one of my pet hates, and I feel so bad to even say that, but it's when people just use the number and don't look at the waveform. While the waveform itself also has lots of errors, if you got a bear hugger on top, if your filters haven't been turned off for the monitor, all these things lead to inaccuracy, but you can look at that waveform to give you additional information and not just look at the number itself. This gets us on to talking about what types of process EEG monitors are there, and by far the most common and the most widely used is BIS. BIS stands for Bispectral Index Monitor, and it's a complex statistical analysis through Fourier's transformation. Essentially, it's doing two things. It's giving us a dimensionless number from 0 to 100, and it's giving us a waveform. We'll talk a lot more about BIS and the outputs it gives us when we look at the past SAQs, but the second process EEG monitor that we have is entropy, and entropy is a measure of signal unpredictability, i.e. chaos in the EEG. In other words, again through Fourier's transformation, is looking at how random these waves are or how similar these waves are, and based on this, it gives us two outputs: state entropy or response entropy. State entropy reflects the level of hypnosis, and typically we say that state entropy less than 60 is adequate for anesthesia, while response entropy has faster response time and provides an earlier warning of arousal compared to state entropy. Again, we'll touch on this a bit more when we look at the past SAQs, but to be honest, I didn't really know too much about entropy apart from what I just said before, because typically when you were asked about what processing monitors you knew about, you'd say BIS, and if they said what other ones, you'd say entropy, and that was usually the extent of the questioning regarding entropy. And I think this moves us nicely into looking at those past SAQs. Going back and firstly looking at the past SAQs with electrophysiology, and like I said at the start, there aren't any recorded on Mac 95. There were some SAQs that were mainly about either skeletal muscle or smooth muscle, but I don't think these truly apply to nerve conduction physiology. Those kind of SAQs looked at comparing and contrasting a single twitch and a tetanic contraction in a skeletal muscle fiber, describing the process of excitation and contraction within a smooth muscle cell, and then one of my least favorite questions, which was briefly describe the effects of resting muscle length and load conditions on tension generated by skeletal muscle. How do these factors affect velocity of shortening? All these questions were pre-2013, and even in the KICM exam, the only question I could find that I think was truly relevant to us was asked back in 2017, which was explain the mechanism responsible for cell resting membrane potential, 60% of the mark, and describe the Gibbs-Donnan effect, 40% of the mark. And to be honest, we've already kind of discussed what you'd put in this answer at the start of this episode. So let's move on and look at the past SAQs related to sleep and EEG then. The last SAQ that was asked about sleep was from 2016, which was describe the physiological effects of sleep on the brain and the respiratory system, which had a very good pass rate of 75%. Here the examiner report stated that most candidates had a good grasp on the EEG changes that occur in both REM and non-REM sleep. Better answers included details on sleep architecture, the duration of sleep cycles, the frequency in which they occur, and the proportion spent in non-REM and REM sleep as sleep progresses. However, what's key to note is that the effect of sleep on respiratory system was not well answered, and there seemed to be a lot of confusion between what changes occurred between REM and non-REM and what the magnitude of changes were for those sleep cycles. I think for this question, the ketamine nightmares model answer is the easiest one to remember. This question just really relies on a lot of numbers being regurgitated. And for this question, I would start off with a generic statement defining what sleep was, and whether you just said it was a reversible state of unconsciousness or something along that line, the examiner report stated that that would be fine. And then you can talk about the sleep architecture itself. So remembering that a sleep cycle is 90 minutes, the end of that cycle is when REM sleep happens. Typically for an adult, you get sleep between 7 and 8 hours, and REM sleep makes up 15% of their sleep cycles. As we get closer to the end of our sleep, REM sleep might start to increase, as well as if we're more tired, and in neonates you see a lot more REM sleep compared to the elderly. Then we can talk about the EEG findings that you see between REM and non-REM sleep, and how you go from the initial alpha and theta waves down to the theta waves in stage 2 of non-REM with the sleep spindles and K complexes, followed by the theta and delta waves, finally the predominating delta waves in stage 4 of non-REM sleep. In contrast, you get those beta waves in REM sleep, and here, if you have time, because all these things are just numbers, you could talk about the CMRO2, the cerebral blood flow, and how those two things would be increased in REM sleep versus non-REM sleep. Then specifically looking at the respiratory system, you can start off by looking at the minute ventilation, which is decreased in non-REM sleep by 15%, both due to a decrease in respiratory rate and a decrease in tidal volume. You get a decrease in the response to O2 and CO2, leading to higher resting CO2 levels. You get a decrease in your airway muscle tone, leading to an increased propensity of OSA. And then, in contrast with REM sleep, that muscle tone is impacted even further, being the highest risk of having sleep apnea. The minute ventilation becomes irregular and may even increase due to an increase in rest rate. You get a further exaggeration in your decreased response to O2 and CO2. And here you can put in your high risk groups. So those patients that have severe respiratory disease or severe central disease are more likely to have complications or mortality or morbidity during REM sleep compared to non-REM sleep. And I think if you touch on all those points, you will do well in this question. What I personally think people get bogged down on, especially with the respiratory system, is only focusing on the upper airway muscle tone and not remembering talking about the effect on O2, CO2, as well as the effect on minute ventilation. Moving on to our last SAQ for today, which was asked quite recently in 2022's second sitting, which was describe the generation and features of a normal awake EEG, and part B of this question being briefly outline the processing performed by EEG monitors, e.g. BIS or entropy, to produce a single dimensionless number from the EEG. The key thing with this question, which has a low pass rate of 36% and was asked previously in 2017 with a pass rate then of 23%, is that it's asking you to explain what is the processing performed to give us that single number. So it's not specifically asking us to go into detail about BIS or entropy, but more so, what is your knowledge of how that EEG is taken to then give us that number? And this is reflected in the examiner report, specifically in the examiner report from the 2017 question. Essentially, this examiner report gives you an amazing definition of what an EEG is, which is the summation of excitatory and inhibitory potentials of the cortical pyramidal cells. EEG is typically small with low voltage in the order of 0 to 200 microvolts, and the EEG is characterized by its frequency and amplitudes of the waveforms. In a normal awake individual, an EEG is asynchronous with low voltage and high frequency. And if you were able to clearly state that, along with the main EEG waveforms that you see that we've previously discussed, you would pass the first part of this question. With regards to the second part of the question, what they were looking for was how that EEG, which is complex in nature, is converted into a single number. And this requires multiple techniques. And if you just said that there's multiple techniques involved, that would already show that you have a good understanding. These type of techniques involve a time domain analysis, e.g. a burst suppression, a frequency analysis, e.g. a beta ratio, a spectral edge frequency, and then other things like biocoherence, which analyzes the waveform. Now you can make an argument, do we actually need to know those specific terms? Because how does that impact what we do clinically? But on the flip side, if you know those numbers, say you recognize that the burst suppression is really high, that's another important information output that's telling you that this person is under too deep of a general anesthetic. So I can see the argument either way, and I think to best answer the second part of the question, the Propofol Dreams answer and explanation how BIS and entropy produce those single numbers is the best explanation I read anywhere. So to start off with the model answer for this question, you just regurgitate what the examiner just told you about your definition of EEG, then you go through what the normal awake EEG patterns are and the waveforms going from gamma oscillations to beta waves to alpha waves to theta waves, and leading to delta waves being the lowest frequency and the highest amplitude. Remembering specifically that an EEG is looking at the potentials that are modified by the brain and soft tissue at the head, and these are recorded by the scalp electrodes. Within this, you're looking at not only excitatory potentials, but inhibitory potentials, and these can be either the continuous or rhythmical potentials, the transient potentials, or the background activity. The key thing is the raw EEG is complex and it requires an expert to interpret it, which we aren't. And so therefore we have a processed EEG, and this is the key thing you need to say for the second part. It's taking a complex data form, spreading it out, looking at it individually, and then spitting out a number which takes that complex data and simplifies it for us. So how does the BIS actually go about doing that? The BIS takes the raw frontal EEG and it breaks it down into components of the sine waves through a Fourier's transformation. Those components are further analyzed with respect to their frequency distribution, and to analyze them, you look at small chunks of data known as epochs. So you look at small 5 to 6 second chunks. In those chunks, you extract what the frequency of the waves are and what phase of the waves they are in. Using the proprietary algorithms, there are then different types of analysis that are then done on those small epoch data sets. The first type of analysis is a time-based analysis, and this looks at the burst suppression ratio. So this is the percentage over a 63-second period in which burst suppression pattern is seen. The second type of analysis is the frequency domain analysis. So here you're looking at those epochs, those time interval packets. If you're getting an increase in frequency and a decrease in amplitude, you're going into a higher BIS reading. If you're getting a decrease in frequency and a higher amplitude, you're going into a lower BIS reading. Therefore, your depth of anesthesia is getting higher and higher. You can also do a spectral edge frequency, where if you drew a line where underneath it 95% of the waves were under this line, where will that line lie? And then finally, you can look at those waveforms and see if there's anything called biocoherence, i.e., in my head what this means is, do those things look like they have synchrony or are they out of sync? And if they're in sync, they have increased biocoherence, and if they're out of sync, they have less biocoherence. Using all those types of domain analysis, that's how the BIS ends up giving you a number and a processed EEG to look at. In contrast with entropy, it's not really doing those time domain analysis. It's mainly looking at the frequency domain analysis. Because it's in its name, it's looking at whether there's chaos or some kind of pattern. Either way, to achieve that frequency domain analysis, it still needs to go through a Fourier's transformation of that raw frontal EEG and break that EEG into multiple sine waves so that then it can analyze it. A special tool is then used known as the Shannon function, which essentially measures the disorder within those waveforms, and any interference from external sources is then filtered out, leaving us with two outputs: response entropy and state entropy. Response entropy contains both the EEG and EMG, while state entropy predominantly is made up of the EEG itself. Both those numbers are again giving us a dimensionless number from 0 to 100, and generally speaking can be interpreted in the same way as a BIS, where less than 60 is thought to be adequate general anesthesia. So I hope this last SAQ didn't confuse you too much. There is a lot of technical words whenever you talk about an EEG, but if you just remember the key thing, that you're taking a raw EEG, you're processing it, breaking it down, and then looking at where those EEG waves sit, either via time domain analysis or a frequency domain analysis, to then give you an output of a number and a waveform. That is as simple as you can make it. And I think that's a good way to end this episode, which really should be an episode that only has 3 learning objectives, so it should be very straightforward. But like you guys see, nothing in this curriculum is straightforward. Even the most simplest learning objectives you can do a deep dive on. But I think that does it for me for today, and I wish you guys the best of luck with your studying, and I'll catch you next time on Count to 10.